Hello, everyone out there in SADS Foundation land. Great to see you. Great to get to be with you on this December 30, 2025. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic, and our Winland Smith Rice Sudden Death Genomics Laboratory. But as in the previous 172 times, here for episode 173, I'm here on behalf of the SADS Foundation. Your foundation, the Sudden Arrhythmia Death Syndrome Foundation, devoted to families with genetic heart rhythm conditions like long QT syndrome. Is that yours? Like CPVT, Brugada syndrome, and the arrhythmogenic cardiomyopathies of ARVC and so forth. Whatever is your lesion, your heart condition, I hope that you find this your home. We've tried our best for it to be a home that takes care of your needs. And we're coming to the end of the year. So if I missed you before Christmas and didn't get to wish you happy Hanukkah and a Merry Christmas, I do so now. But now with 2 days left on the calendar, less than 48 hours, and 2025 is in the books, I give you one final reach out to the SADS Foundation. Go online, www.stopsads.org. or www.sads.org. Top right corner, donate now. You still have time to wrap up 2025 with your generosity, and we would welcome that. Our director of development, Ken, laid out an ambitious goal. We're very close, and we could use your help to get to reaching his goal and breaking his goal that he set for. So won't you give to the SADS Foundation? I see questions coming in, and I'll come to those. But before I take that, there's been a question that has been coming to Genevieve. As you know, she is amazing on our team about cold and flu season and what can we take and so forth. Is Tamiflu safe for the flu? What about decongestants? And I'll give you an overarching guide. Again, I'm not able to give you your personal direct medical advice. The same with your questions that you pose. I can't give you direct advice. I try to take your question. But with the question of cold and flu season, what say me? First of all, from my standpoint, for all of my patients, no matter what genetic heart condition they have, any of them, they can basically take anything that's over the counter for a cough, cold remedy. I don't fear any of them. Now, where is there yes, but? Yes, the yes, but comes with the decongestants. There are some decongestants, Sudafed or pseudoephedrine, for example, that shows up on the QT drugs do not take list. Great website, www.crediblemeds.org. I recommend it for all of my families with long QT syndrome. That list of medicines, by the way, is not relevant for any of the other genetic heart conditions represented by our SADS families. But for long QT syndrome, they've been advised to not take any of those medicines, which cause many of my long QT families to be called miserable during cold and flu season. I've stopped recommending the decongestants as must avoid for 20 years now. And so that list is very important, very helpful, but it's not an absolute contraindication list. And so for my own assessment, the ones that are over the counter, I think are largely safe. Now, would I take several over-the-counter medicines that are on the hit list and take them at the same time? I probably would not. But do we have margin to take one of them? Like if I'm miserable with the cough, to take a cough suppressant, no concerns. Dextromethorphan, Robitussin, no concern. Do I suggest with congestion to start maybe with Vicks VapoRub where there's no concern? Yeah, but if we need to be in a decongestion, do I worry about nasal spray, Afrin decongestion? Not at all. What about an oral pill decongestant? Not really. So don't be miserable this cold and flu season. Am I worried about Tamiflu for any of your conditions? I am not. So if you have one of these and you've been miserable, take care of yourself. What about the flu shot? I think We would just follow the guidelines across all of the cardiac societies, the American Academy of Pediatrics and so forth, about getting your annual influenza shot if it is age recommended and age appropriate. There's nothing about the influenza vaccine, the flu shot, that gives me any concern for any of the heart conditions represented. Now, on to your questions, or the rest of your questions, since that was a big one that's been coming in to the SADS Foundation since we've been last together. So we're going to start. The first one is Malgorzata. So hello there. That looks like a new name. So welcome to SADS Live. And she's stating that her recent ECG showed a QTC of 500/5 in one of the leads, lead 2, 480 in lead V5. In lead 2, the Q wave was not visible, while in V5 it was. Which lead would I consider more reliable? And how should one interpret such discrepancies? Great question. I'd love to have you on my research team. Basically, I like lead 2 and lead V5 for my leads to independently confirm whether I agree with the computer's QTC. Now, do I go with 505 in lead 2 or 480 in V5? In this case, my own assessment, I would be looking at you as on that day being 505. Do I worry that 505 is scary and 480 is relaxing? No, it just tells me that now you are 505. And depending on is this your normal, is this a person's norm, or are they trending higher? If they're trending higher, why? Is there something else going on that's making the QTC longer? For a woman, where am I in my monthly cycle? Because we know that the QTC fluctuates based upon levels of estrogen and progesterone in the body during the monthly menstrual cycle. And so I don't view it as a discrepancy. I just would use those as my guideposts to determine. So if I'm using a medicine like Mexilatine, where I'm trying to shorten or improve the QTC, I just try to stay consistent with which lead I'm using. But I do like those two leads, limb lead 2 and precordial lead V5, the best. Great question. Merrick is asking whether are all R-on-T PVCs due to after depolarizations, or can they arise from the outflow tract? Does the mechanism, whoa, this is pretty in the weeds. Wow, this is a good question. Well, the question that's being asked is about PVCs, premature ventricular contractions, and where are they coming from in the heart anatomically, and where are they hitting the cycle of the previous normal sinus beat? So there's a couple different things to unpack there. One is about the cellular mechanism, and often for PVCs that are long QT PVCs, if you will, we say that those are from early after depolarizations. And if that early after depolarization of reactivated sodium channels, for example, strikes the heart early, such that it's hitting, that PVC is hitting on the previously normal T wave, that's where it's called the R on T. And that cycle coupling, if it's that early, then that could potentially trigger the long QT danger rhythm of torsades. Now, you can have a PVC that can come from anatomically the right ventricular outflow tract and still be an early after depolarization in its cellular initiation. So not all PVCs are the same, but basically wherever that PVC is coming from anatomically and by whatever mechanism, if it's encroaching on that T wave, then that could potentially trigger. So I do have a few patients with long QT syndrome and, oh, by the way, unrelated RVOT PVCs coming from the outflow tract. And sometimes, very rarely, have we elected to ablate those PVCs because we didn't like how close they were coming in proximity to the person's long QT interval end of the T wave. So there's more that could be unpacked there, but that's probably enough because that's one of the the deeper ones of the day. Great question, Merrick. Jamie's asking me about their 10-year-old daughter who has CPVT and is RYR2 positive. So when they are RYR2 positive, we say that they are type 1 CPVT or CPVT1. She currently takes Nadolol and flecainide. Great, I love both of those. However, her stress tests still show numerous PVCs. Her doctor is recommending left cardiac sympathetic denervation, LCSD surgery. What criteria do you use to determine if it's the best next step in treatment? Wonderful question, Jamie. I love it. Basically, my goal, and the goal I would say of the CPVT world experts, if you will, in the past, the guidelines have indicated that the presence of couplets or worse on the stress test on therapy means that we need to do more. We need to intensify the treatment. That the presence of couplets or more was an indicator that we do not have the CPVT1 substrate under good enough therapeutic suppression. So that's the line in the sand by the guidelines. Now, most of us have moved the goalpost towards making the patient's ECG normal, identical to mine, getting rid of all PVCs in bigeminy, and even frequent single PVCs. So I don't mind the notion about treatment intensification because of the residual PVCs. But again, we're pushing that goal of PVC suppression beyond what the guidelines have currently endorsed. I tend to do it myself. So I try to cure, quote unquote, cure the stress test. What are my options? Well, it depends on the dose of the Nadolol. Do I have room to up titrate the Nadolol? What about the dose of the flecainide and the flecainide trough level, which I use in all of my CPVT patients to guide the result of the stress test with what flecainide trough level that dose has generated. And then if I'm kind of at optimized doses and I'm still having that level of an unsatisfying stress test, absolutely, I bring my patient to what I call triple therapy with the addition of the denervation surgery on top of the combination dual drug therapy. So that's how I do it. What about from Instagram? It looks like Zofluza. I've heard this has less side effects in general versus Tamiflu for children. I like that one too. So I have no concern about either from the standpoint of QT. I know there's a rare, uncommon side effect of seizures with Tamiflu in children. It's pretty rare. And I'm not sure if that's been reported with the other flu remedy of Zofluza, but I'm not worried or concerned about either from the QT interval or the CPVT or the ARVC or any of our conditions. Marion is wondering what I think about magnesium and is it good for LQT1? I don't mind it. In general, we know that diseases or nutritional states that could result in low body magnesium, hypomagnesemia, can be QT agitating, can be proarrhythmic. And that's why if a patient comes in to the hospital after an episode, we always check the serum magnesium level. And if it's low, we correct it. We try to normalize it. Now, do I need my long QT patients to be on a magnesium supplement? Almost never. If you want to be on one, no problem. But when the magnesium level is normal, the body kind of takes any extra magnesium and flushes it out the system. So I only have magnesium for my patients, for example, who might need a proton pump inhibitor for heartburn, reflux, GERD. And we know that chronic use of a PPI, a proton pump inhibitor, can cause the magnesium levels to kind of drift down. And so for that kind of a patient, I might have them take a magnesium supplement if we've demonstrated that the magnesium drift is occurring. But for most of my patients, I tell them, spend their supplement money on other supplements or on a latte. So no, I don't need a person to be on magnesium otherwise. Mandy is asking, Happy New Year. Well, thank you. Happy New Year to you. And she has LQT2 from a KCNH2 mutation. I love that you guys are knowing your gene when you say I have CPVT1 or LQT2. Great job. Is perimenopause, menopause a high risk time? Good question. Short answer, no. I'm not convinced of it at all. We did write a paper from the LQTS registry based out of the other Rochester, New York, suggesting maybe a higher risk. I just have not seen that in practice in my LQT women, LQT 1, 2, 3, anything, as they transition in and through menopause. I think we do know with confidence that all things considered, females in their estrogen generating years, their menstrual cycle years, are at higher risk than when they were a little girl. And we know that during their pregnancy window of life, that the pregnancy phase is not higher risk, but the postpartum phase, the first 6 to 9 months after giving birth, might be slightly higher risk. Now, I say might be because it's the true statement if you are an LQT2 woman not diagnosed yet and therefore not treated yet. I don't think the postpartum window, for example, is much higher risk time of life at all if you've been well diagnosed and well treated. So I think we largely neutralize that window of increased risk in our diagnosed patients. And we're, looks like a bonus question because I see that Instagram post for a second time, but I'm going to give it to you. I'm feeling like Christmas spirit. Your 9-year-old son recently has shown long QT on his ECGs, but passed his exercise test. But at rest, it went back to 478 at 7 minutes. So that sounds like 7 minutes of recovery. My sons are very active, and I feel very overwhelmed. So really good question. I would say don't be, because all we need is methodical detective work. We have to first prove to ourselves, does the person, in this case, the 9-year-old son, is the person's QT interval behaving normally, yes or no? If we think it's maladaptive, not reacting normally during the different phases of stress testing, such that we are pondering the possibility of long QT syndrome, then we have to get genetically tested. And if the genetic test comes back positive, then that just confirms that that ECG observation is probably true, and related. That number of what the QTC does during the stress test, during the recovery phase, carries almost zero risk forecast ability. So I would say if we don't know whether we have proven long QT syndrome status by a positive genetic test, then in my program, if I don't like the QT during stress testing, then I proceed with long QT genetic testing. No, and hello, Angie. Well, I look forward to meeting you since you're right here. And that is wonderful. Great to see you. Thanks for the note. And I trust everything has gone as it is supposed to go here. And she's sharing our denervation surgeon's name. And I'll just give a shout out to Dr. Stephanie Polides. So prior to her being trained in about 5, 6, 7 years ago now by Dr. Chris Moyer, where he and I started the denervation program at Mayo Clinic in 2006, he had done the world's most denervations. And I think quickly, Dr. Stephanie Polides has caught up to that and might be passing it in the near future. So she's done either the second most or now is the front runner. Is just a wonderful surgeon and a wonderful person. And I love having her on our Mayo Clinic team. So thanks, Angie. Brandy is asking if there's a way to help lower PVCs. I have ARVC and I have PVCs all day long. My doctors aren't concerned, yet it is very uncomfortable. That's a wonderful question, Brandy. So in this case, we would call Brandy's situation symptomatic PVCs, because we can have patients who have PVCs, some of them 1,000 a day, some 5,000 a day, some 10,000 a day. And if they don't care about them, they don't feel them, they're not annoyed by them, I don't care about them. Now, you could have 4 PVCs a day, and I feel like I might need to get rid of them, because it all depends on the nature of that PVC, where it is coming in the cycle, that R on T possibility, where it's located in the bottom chamber. Is it outflow tract? Is it somewhere else? And so forth. Now, in her case, she has ARVC, arrhythmogenic right ventricular cardiomyopathy, and the PVCs are probably coming from that irritable areas in the right ventricle, whether it's the apex, the bottom, or the outflow tract, and so forth. Now, do we need to try to get rid of them? Well, the answer is it depends. In this case, in our program, the answer would be we should be trying something, because she's feeling them, not liking them, symptomatic with them. And so we would be exploring, is there a role for any medications? Is there a role potentially, and this is an uncommon use in our program, but potentially for ablation? Is there one particular area that's responsible for the vast majority of those early beats, those skip beats, those PVCs? So it's a great question. The answer is a little bit complicated, and it needs to be tailored and personalized to your exact situation, your genetic makeup, what kind of ARVC. I'm guessing probably PKP2 mediated ARVC. Where are the PVCs coming from? Is there a predominant guilty site in the muscle that's contributing to the majority? Can I try medications and so forth? But whenever my patient doesn't like them, then I don't like them. And in our program, we try to do something about them. Bella, I love that name, or Belle, our dog, our Brittany Spaniel, who has been with us for 11 years now. Her name's Bella. Can I speak to the safety of natural remedies for coughs and colds in someone with long QT syndrome? Great question. I'm not sure what are the names of the natural remedies that you might be having in mind, but in general, I'm not aware of any of them that have QT prolonging ingredients in them. So I think there's just important to just double check the list and make sure that there's not substances like, and these won't be cough and cold, so it doesn't matter. But for a while there, a favorite supplement was cesium chloride. Not a good idea for long QT syndrome, because the chemical cesium, or the element cesium, and the chemical cesium chloride is a potassium channel blocker. So that turned out to be a potentially dangerous supplement. So I think they're likely safe, but I don't know the names for which I would normally be doing a cross check like you would to see what's listed. How Alona's asking, how accurate is the ECG Plus app when it comes to the QTC? So the ECG Plus app, I'm not sure if you're referring to the app for the smartwatch, but I would say in general for a patient's trend, I like these home monitoring devices. We have one, full disclosure, we help create QT logic in a smart QTC analysis for the AliveCore cardiomobile device. It's FDA cleared, but by prescription, so it's not readily available yet. That's been a bit frustrating, but they're coming along. So these ways of monitoring your QTC at home are improving. I still think there's probably some shortcomings with the ECG Plus app. I don't use it myself, so I can't speak with great authority on that. So good question. I'll have to do some work on that. Oh my goodness, Redmond is getting the trifecta of 3 of them. So just normally we only do 1 for you, but I'm just taking everyone in order. But I'm going to give you, because it feels like you might be new and this is a new journey for you. So don't worry, we'll hold your hand together. But do doctors usually do blood tests to check electrolytes, potassium or magnesium levels, or is that not common? Not very common for long QT syndrome. I don't. So I don't need to if the person is otherwise a healthy individual. Now, if they came in with a vomiting and diarrheal illness to the emergency department and they have long QT syndrome, would I be checking them? Absolutely. But routine, I don't check them for my patients' normal annual visit for their long QT status, with the exception that if they're on mixilotine, I tend to get electrolytes at least once a year. And in my program, if they're on that anti-GERD reflux medicine of a proton pump inhibitor like Protonix or omeprazole, the names don't matter, then I would check a magnesium level. We used to check magnesium levels in them quarterly, every 3 months, and I just found that to be a waste of time and money. And so I basically, once I've proven that they're not leaking or losing magnesium, I probably do a surveillance check for my patients on a proton pump inhibitor for their GERD, maybe once a year, but it's not routine. Michael, nice name, have ARVC and have been on amiodarone for a couple years. Any concerns with long-term use? So for Michael with his ARVC, he's on a medicine that has been used. Again, I don't know the why amiodarone was chosen, if other medicines were trialed or if that one was started. So it's difficult to comment. I can just speak in general for my young patients, so my age or younger. I try to use some of the other antiarrhythmic medicines before going to amiodarone. So the younger they are, the harder I try. It's a great medicine. It's used in some of our ARVC patients. But long-term use, there are some side effects of long-term use of amiodarone that can be concerning. The thyroid issue, many patients need to be on thyroid supplement if they've been on amiodarone chronically. And then, of course, the rare but significant side effect of pulmonary or lung fibrosis. Sharing that a sister has endometriosis and what is the best thing to help it? Great question. And this is one where, as the long QT or genetic heart specialist, I have to stay in my own lane. So this is where I would be partnering with the obstetrical gynecologic team, working with the gynecologists rather, to see what are their recommendations. Most of their standard therapies would be QT friendly, CPVT friendly. I would not have a concern, but I would not know what is the latest treatment strategy for endometriosis. So I would probably have to use ChatGPT to get started as an insight. So a great question, but I just don't know that answer and will not try to pretend. Val is asking what to do if a newborn is diagnosed with an SCN5A mutation and dad looks to have the SCN5A Brugada side of the equation. Remember, mutations in the SCN5A gene that builds the sodium channel called NAV1.5 can show Brugada syndrome if the mutation damages that channel in a, quote, loss of function way, or it can show type 3 long QT syndrome if it causes the sodium channel to become so-called leaky with late sodium current. But we already know that dad is showing Brugada, so most likely the baby would be having a tendency towards the sodium channel Brugada variety. So what do I do in that setting? I would just be getting an ECG on the baby sometime, not emergently for sure. Let mom, dad, baby bond, no baby snatching. Way too many places are ruining the newborn experience. And I say ruining because the families have told me that, by snatching the baby away for an emergent ECG right at the moment that the cord is cut. Don't need to do that. Just let the bonding experience, that wonderful moment, occur. then sometime during that first day when mom is needing a rest and baby is alone, we can get a newborn day 1 ECG. There's not an urgency because Brugada expressivity in infancy is super rare, but I would just be getting it out of curiosity to say, does the baby show the Brugada pattern? Then I would check it again the next day. And then if it is showing it, then we counsel about Brugada preventative measures like fever. Again, we have to be careful with a newborn that we don't lower fever immediately, because in the first 6 months of life, fever needs to be addressed as why is an infant having a fever. But for the most part, once we're past that stage, we talk about judicious use of antipyretics like Tylenol, acetaminophen, and so forth to lower body temperature. And I was right. So Jay Redmond is new to this and is scary and is just beginning. So I'm glad we violated my own rule and gave you multiple questions to get you started. I hope this has helped making you less scared. Please don't be scared. And your help will be welcome. And Lauren, longer questions with 9 minutes on the counter. So I'll try, but reminder to keep questions tight so I can look over briefly. But here we go. Lauren, your daughter had a fainting spell at a young age. The EKG at that time was normal. Years later, she contracted COVID, never had the shot. Her EKG showed LQT type 2. She had a genetic test done and it was an unknown variant. Doctors state it's genetic and will be on natal all the remainder of her life. Is it likely genetic since she has had a normal ECG in the past? Is it possible that COVID played a part? Any research being done with long QT and COVID? There's a lot to unpack there. So I would say, first of all, you need to have that genetic test result reviewed carefully to decide, is it really a variant of uncertain significance, or is it only a VUS to the genetic test company that because of their rule set, they were not able to do a variant promotion to a likely pathogenic variant. And then we have to see, does that ECG really look like LQT2? If it does look like an LQT2 pattern and the person has a KCNH2 VUS, then maybe that VUS is not unknown, that it's actually contributing. Then we have to figure out, okay, so if we're showing it, how much are we showing it and do we need to treat it? And so that would depend on a lot of factors that I can't comment on here, but a careful evaluation would be strongly recommended. As to the relationship of COVID, there has been some research. Our lab has published some of the key early findings that show that in the dish, that if you gave the cardiac cells the spike protein from the COVID SARS virus, that could cause QT lengthening in the dish at the cellular level. Then during COVID, it was shown that the ECGs of COVID patients showed longer QT intervals than normal patients. So I think it is fair to say at the cellular and at the clinical level, there is a mild QT prolonging effect from the virus. And so that doesn't surprise me. And does it stay? I doubt it. I suspect what we're dealing with here, this is a guess, that we probably had an otherwise weak LQT2 variant for which the virus acted as an exogenous add-on to make the QT profile a little more obvious. But again, this daughter needs careful evaluation. And Ramy might be the last one. We'll see how I do here because I'm scrolling through. Kind of weird. He or she is saying that I had a cardiac arrest last November, so maybe just a month ago, with no heart conditions, clear of all heart problems. One thing for sure, that I was transitioning from perimenopause to menopause. But I also found out I have sleep apnea and I'm now getting CPAP therapy. I don't have the condition you're speaking of as well, just food for thought. Yeah, I'm glad you're doing well. and have survived that. Again, a lot to figure out or to sleuth from a detective work. But again, in general, I have not found my patients, my women, females with Brugada, CPVT, ARVC, to be twitchy or pro-arrhythmic as they transition from cycles to menopause. Just have not seen that. Let's take Lindsay's as the last one of 2025, Lindsay. And Lindsay's question is, she has Brugada syndrome, and her heart rate continues to vary from 80 to 120 during rest, even at night. It usually coincides with painful PVCs. What are my options besides medicines, as I am on them and am still having trouble? What questions should I ask, or what should I do to better my way of life? I think, Lindsay, with a situation like this, one, PVCs, isolated PVCs, is not Brugada. So Brugada doesn't do PVCs. So we have to figure out, why does a Brugada patient, a long QT patient, a CPVT patient, any patient have PVCs on their Holter or ambulatory PVCs? Because those aren't part of the package deal. Now, ARVC people, they can have PVCs because they have an abnormality in their right ventricle myocardium, and there might be areas of the right ventricle that are diseased and are PVC producing. But an otherwise healthy long QT person, CPVT, Brugada, they don't have, oh, by the way, I have a lot of PVCs. That's just not the norm. So one would need to do the detective work to figure out how many PVCs are you having? Where are they coming from structurally, anatomically, and what are the options to make them less? And again, as I mentioned earlier, if you're not having symptoms and there's not a lot, less than 15,000 a day, I kind of disregard them. If you're having them and you don't like them, you feel them, now they are symptomatic PVCs, and I need to be trying to see what can be done to make them less. So once we've done that detective work, then we would look at, what are the medication options to try to make them less? What are the potential non-medication ablation options to make them less, and so forth. Well, with that, we are bringing the year 2025 to a close. I know for some, it's been a very hard year. For others, it's probably been your most tragic year of your life, where you have directly experienced the loss of a loved one from sudden cardiac arrest that culminated in sudden cardiac death. And so for some, you are ready to bring this year to an end and trusting that the new year is better, more hopeful. For some, it's been a great year. And so we celebrate the highs and we grieve and we are aware of the lows of 2025. But for all of us, as we bring it to an end and we bring a new year before us, I just wish you a happy new year. And I trust and I pray that 2026 will be a rich and invigorating year for your life personally, for your family, for your soul, for all of you. And for all of you, I am indeed grateful to get to have this be a part of my life for the past several years now. I have loved SADS Live, and I'll be back with you in 2026. But the first SADS Live of 2026 will be Friday, January 9th, but not with me. It will be your questions and answers from Dr. Andrew Landstrom, a member of the SADS Foundation board, and one of my now long ago former trainees and one of my career prizes. So enjoy your Q&A day, the first one for SADS Live in 2026. Mark your calendars, January 9th with Dr. Andrew Landstrom. Till then, be well. Blessings to you all. Happy, happy New Year.